Well, hi, everybody. Thanks for joining Civic's monthly Change Agent Chat. My name is Jay Want, and I'm Civic's Chief Medical Officer, at least for another day or two. Before we get started, there are just a few housekeeping items to mention. The phone lines are muted, and we'll be using the Q&A feature to field questions that will allow you to make comments on the discussion. Questions posed, we may answer them during the flow of the chat, or we may save them to the end. Most often we do the latter. This webinar is actually being recorded and will be posted to the Civic website, so you may access this information again at any time without any cost. So we've been saying for months now, and I'll repeat it one more time, the definition of insanity is doing the same thing and expecting a different result. In the case of American healthcare, it means that if we don't change things, we get to keep spending twice as much as our industrial competitors around the world and getting worse results. I'm convinced that we can do better, and that the different and better ways are unlikely to come from somebody's central plan. It won't be ours, it won't be Washington's, it won't be anybody's. But instead, I think what we found actually by looking is that innovation in the 21st century is likely to come from the local level, and in particular communities where people find ways to work with one another. And indeed, when we did look, we found many examples here in Colorado. With limited resources, these change agents are starting to deliver on the promise of the triple aim: lower cost, better population health, and better patient experience. We're excited to bring these people to our stage so we might all get smarter together. So today we're really fortunate. We have Dr. Joseph Johnson, who is the medical director of the Dawn Clinic, which stands for Dedicated to Aurora's Wellness and Needs. Dawn Clinic actually opened in March of 2015, and it had basically two goals. One is to provide access to integrated healthcare to the medically underserved adult population of zip codes 80,010 and 80,011 in Aurora, and two, to create an opportunity for hands-on experience with integrated team-based primary care for medical students. Reading through the write-up that we did a few months ago about this, also kind of unique in that it was actually the students who ended up lobbying their deans basically for resources in order to be able to do this. And we were thrilled, basically, to be able to kind of publicize their launch a little bit. Joining us today is Dr. Joseph Johnson, and we're happy to welcome him.
Thank you very much. I appreciate it. Happy to be
here. Great. So I think Civic last talked to you a couple of years ago, and at that time, the clinic was just starting up, and you were seeing maybe 5 patients, then 15 patients a day or whatever. Catch us up a little bit. What's happened since then? If things continue to grow, or how's it going now?
Yeah, we've definitely filled out our ranks, both from a sort of volunteer network perspective and also from a patient perspective. But we are almost entirely a volunteer organization until just recently. And so we've been open 1 day a week on Tuesday evenings from, we start seeing patients about 5:30. And then we finish when we finish. So sometimes I get home 11:30 in the evening.
Wow.
And we have never advertised. We don't even have a sign on our door, to be honest with you. But nonetheless, we have had pretty consistently full clinics on the average of, it's temporal. Our population is the uninsured and uninsurable population in original Aurora, which is a heavily immigrant community. And so we're seasonal in nature. So the winter months, we see probably 12 patients per week on average. And then in these summer months when the day laborers are available and around and working hard, we see probably 20 to 25 patients per week. That is, as our population's established, that proportion is ballooned in chronic disease management. We are a primary care clinic first and foremost. We are not an acute care clinic. We do acute care, but that is not our mission. And so had fewer walk-in patients that we're able to take, especially this summer. I think that a lot of our undocumented patients were not frequenting anywhere after the election and the inauguration. And since the sky hasn't quite fallen, although it is still tenuous for many of these families, they've come back out of the woodwork, a surge in volume. And had for the first time to turn some people walking in away. Our solution to that's been that we just are proud to have hired our first employee who's a full-time nurse. named Sally Garcia,
cool.
who ran the labor and delivery unit at St. Anthony's North. She previously has run the high-risk maternal fetal medicine group at the university in another era.
Cool.
And so she brings an excellent mix of sort of leadership and management experience, teaching experience, and also patient care. And she's extremely passionate about this community and this population. So we're hopeful that a lot of that routine chronic disease management, disease education, monitoring of mainly diabetes and hypertension are what we're seeing, as well as some pulmonary diseases, that can be taken into a separate clinic for nursing only that our volunteer docs are following peripherally and getting involved on Tuesday nights when necessary, which will in turn increase our volume again. But
Great.
the part is that we've never advertised. Our patients come because of word of mouth, because the community is proud and happy with the work we've done, and folks are sharing with others. So we're pretty much pumping on all cylinders now.
So I'm having a little trouble actually envisioning this, because I expected it to be a lot of acute care, but you're saying there you actually have continuity. You actually have people coming, week after week or several months in a row. And so do they end up seeing the same medical students, or how does that actually work?
It depends. I mean, I think that some of our students self-select to be regulars, those who are internally motivated to develop their skills in underserved care and are passionate about this urban medical work. We're still student-run free clinics, so there's students that fill our student leadership areas, our care coordination groups, there's scheduling students, there's students that are in charge of specialty connections and networking in that way. There's students in charge of our testing infrastructure and things like that. And now, of course, with Sally being available, we will have more continuity for our highest risk patients in particular. I want to correct real fast that this is not a team-based primary care experience for medical students. This is a team-based primary care experience for every student on the Anschutz campus. So we've got student directors in medicine, nursing, physical therapy, occupational therapy from CSU up north, pharmacy, dental, the PA and NP programs. Everybody's playing a role here, and that's the educational mission, and that's why everyone keeps coming back to volunteer their service, is they learn, oh wow, this is the breadth of value my nursing students colleagues can add. This is the breadth of value that my physical therapy colleagues can add. Wow, they just taught me how to do this incredible Dick's Hall Pike maneuver I never actually was taught in school. I learn a lot from faculty, and so we have 9 faculty members from all the different disciplines there every week as well, and we model that sort of, hey, pharmacy colleague, Dr. Ben Chavez, coming from Salud to volunteer with us. What would your recommendation be for the next step up in this diabetes regimen? I know the answers, maybe I don't, but we try and model that collaborative with our students.
So that's kind of fascinating. So you said some of them are in charge of scheduling or care coordination. So do they end up doing different roles than they will ultimately do as a professional, as a graduate, or is it, or are they, for example, if I'm a medical student, do I just do your job, or do I actually do scheduling and other things?
It's a good question. No, the scheduling and some of the clerk work, that's whatever student is sort of taking on the reins for that, and selecting leaders. The care coordination is more of a pipeline from the community and also from our university as well, pre-health students who come in thinking, I want to go to medical school, I'm in a post-bac program, or I'm still in my undergrad. And we've honestly had a couple of them like, I thought I wanted to do medicine. I want to be an occupational therapist, actually, once they realize what they're doing. And so the care coordinators are there's a whole application process that students direct themselves. They're selecting for Spanish-speaking students that are hoping to get into the school. And we've worked closely with the Dean of Diversity at the University, Dr. Zimmer, to that pipeline as well. But honestly, I mean, when you extrapolate this vision for team-based primary care and to the broader population, the difficulty becomes that there's not a lot of teaching mentors for ambulatory care nursing, for example, in the community. Our work development, this is one of the few places I see that students are getting this experience, and pushing them to want to practice in primary care and such.
So I'm dying to ask you, I mean, how are students changed by this experience? Because it seems like they're getting this kind of view into something relatively rare and inaccessible otherwise. I mean, do they come in with different preconceptions, or do they leave with different attitudes, or how's the experience affect them?
So the sciencey answer is that we're studying this. We do
Cool.
volunteer attitude surveys at starting and after a year. We've seen some statistically significant movement in perceptions of other professions, the importance of primary care in providing health longitudinally for populations, and an understanding of that this can be a dynamic, challenging job, that it's not necessarily just rote sniffly noses that sometimes gets messaged when you're in health professional school. And so on a population level, we've got data showing this is pushing folks into the workforce for primary care. They're still young, and so certainly there's selection bias there. That's probably actually watering down our results more than anything, because everyone's already is all jazzed up to do primary care who self-selection. We're hoping that if we can show movement in this way with this population, that once we are hopefully negotiating with the university, and particularly the interprofessional education curriculum, that in coming years under our new nurse manager Sally Garcia's tutelage, that we'll be able to expand this to a more general population and work it into the curriculum. But that has to be well planned. I don't know if anyone's heard of professional school curriculums are pretty jam-packed already. And so, you know, as Trump would say, you got to drop two things before you can put a new thing in.
Yeah. So, with a multidisciplinary approach, it seems like this would be like the perfect place to be thinking about social determinants of health, and, you know, housing, transportation, all that stuff. Do the students get any kind of experience with that? With, you know, I guess, are they getting social determinants of health training, basically, while they're there?
That's my role within the medical school. I'm a volunteer faculty. I practice full-time at InnovAge, where I'm at right now, actually. But in sort of my academic hat, I do, for the medical residents, a 10-week lecture series on social determinants of health, cognitive biases, and the political economy of healthcare. So I teach that in a structured way, and that's also always something I bring into the teaching with our students on clinic night. And it's a necessity. It's all case-based learning. I mean, we've had folks, you know, right now we've got a gal who is a creatinine of 4 and a GFR of 8, who just diagnosed with this problem for the first time when she showed up with a blood pressure of 220 over 110.
Kidney problems basically related to her hypertension.
Right, and diabetes. And so
diabetes.
Our students, our care navigator, Beatrice Guillermo is her name. She grew up in original Aurora. She's aspiring to go to health professional school. I called and said, hey, we should do a conference call to share these results directly, and you can share them as a Spanish interpreter for me. All of our interpreters are certified as well. And she said, well, why don't I go to the patient's house, make sure that the family is able to be there, and I'll be in their living room. I can sit with them for 20 minutes before you get on and stay after for an hour and make sure they're comfortable and coping with the information you just gave. And I say, I think that's an excellent idea, Beatrice. Why don't you do that? And that's the level of care that these students are aspiring to provide. So they're getting into the weeds with families. They're identifying the risks that are arising all around them. We have another gentleman, only 34 years old, who had a traumatic DVT a couple of years ago, then an upper GI bleed on the warfarin because he didn't show up for a few INR visits despite our best attempts to get him in, which we learned from that. And that followed up with another recurrent DVT when we took him off the anticoagulation for the ulcer another year later. And that's all being overshadowed. We discovered why he wasn't able to keep his INR follow-ups, because U.S. Marshals are coming to his home, bringing him into the courts to testify against his ex-wife, who's a drug mule for a cartel. And then once he was in court with the U.S. Marshals, the ICE agents that are staking it out are aware of him, and now he has deportation proceedings against himself. And so it can go off the wheels very quickly without any social safety net for our population. We've connected him with the Rocky Mountain Insurance Action Network. We've reached out to pro bono lawyers, and that's all our Spanish-speaking care navigators who are doing that aspect of things, while our team continues to manage the anticoagulation. Our physical therapists are managing the compression stockings and his lymphedema.
Yeah.
And some of the back problems he's developing because of a unilateral edema at such a young age, working as a construction worker. So we're thinking of all of these aspects of care and engaging this patient in, all right, when can you keep appointments when you're not going to see your workers' comp docs? When are you going to court? When are you needing to meet with the employers? And we'll work around that for you.
So I'm curious, I mean, even for experienced traditional practitioners, that kind of complexity can be overwhelming, and it can actually be, quite an emotional drain. I mean, I can remember before, way back in the day when we didn't have much of awareness about social determinants of health, always feeling, some sense of helplessness about that. How do the students actually react to that? Because, they don't have all this training yet, and yet they're faced with these, it's like pulling a thread, and suddenly this whole ball of yarn seems to unravel before them. How do they react to that?
Courageously is probably the best way.
That's a good answer.
We're also embedded. The Dawn Clinic is embedded within the Opportunity Center, which is a one-stop shop community hub in Aurora. We're co-housed with a non-denominational church. We're co-housed with Senator Rhonda Fields' family foundation, the Fields Foundation, who actually owns the clinic at the end of the day through some accounting practices that allow us to have that diversity of our organization. So there's housing specialists already in the Opportunity Center. There's a social worker who comes and is part of our team. So the students, they can turn to any number of 10 to 12 people that are practicing to say, what is the best way forward with this?
Yeah.
When we have a situation with domestic violence, we've got Servicios de la Raza on speed dial and talk to their navigators to say, hey, can you jump in and help? So the way we teach is that we don't have to do this alone. We are part of the Aurora community. This is a vibrant area, like a block and a half away, the Second Chance Center, where it's a private, small nonprofit that helps folks reintegrate from prison. We get folks all the time that are out of jail in Texas coming up here to get a fresh start, walk into our clinic when some social worker in the county system hears about them and tells them to come to us. And then we know that they can get some post-release job navigation just 2 blocks away. And that's the grassroots network of students we have too. You mentioned in the beginning that this happened because my students organized 800 signatures over the course of 6 weeks to bring to the now retired Dean Krugman, who said, wow, absolutely we'll support this. This seems to be
that's great.
That made my job easy when they did that. That same group of students is going to town hall meetings with their local congressman. They're going to city council meetings. They're going to do Cooking Matters classes with Colfax Community Network and the Feed Aurora program. And in turn, they're not coming alone. They're bringing vegetables they grew in their community gardens that the seeds are coming from my budget at the Dawn Clinic because we budget for that. We pay for all of the DMV for patients. We recognize that if you don't have a wheelchair and you just had a stroke 3 weeks ago, you're not coming to the Dawn Clinic if we don't provide you first with a wheelchair. And so we pay for that out of my funding streams, and that's all coming directly from the University of Colorado's deans of every school on campus. They
that's great.
Block grant money every year for just supply funding, and we also have a gallon.
A reminder to those in the audience, if you have any questions, please enter them in the chat box, and we'd be happy to take some questions and submit them to Dr. Johnson to see what he has to say about it. So it struck me while you were talking that these students will actually walk into the traditional medical system potentially after they graduate and say, where's the social worker? You're basically renormalizing them to think always in terms of, I don't have to do all this myself. I need help basically to actually care for these people adequately in all the dimensions that affect their health.
I've never worked in the traditional healthcare system in that way. I finished my residency in internal medicine. I did a chief year at the VA where I worked in a global system. I worked briefly for Iora Primary Care, which is a novel primary care practice. And now I practice in the PACE program at InnovAge, where I have an incredible team at my fingertips embedded in our geriatric model. So I hope they're like me and refuse to practice in fee-for-service, because that's not that's not why I went into care. It's not giving me those tools that you're talking about, right? And I expect the same from my students, and that's how you light a fire under the system in some ways. Excuse me. My fiance is looking at wedding venues today in Maine.
Well, we can all help, actually, if you put up the phone to the camera.
Sorry about that. I didn't expect your call to come.
No problem. No problem, not at all. Getting back to we mentioned a little bit that there might be a little bit of uncertainty with goings on in Washington and all that. Can you just comment briefly about how that's affected the clinic over the past couple of years? Either patients that have come or composition or that kind of thing, and what your kind of overall outlook is about that.
Sure, that's a big question. I'll try and make it brief so the audience has opportunities as well. But basically, this clinic would not be possible without Medicaid expansion in the Affordable Care Act. This was tried. CU Cares Clinic in the early 90s. Dr. David Price, who I believe is an executive at Kaiser in the area now, we reached out to him. We've spoken about that experience, and they went bankrupt in a year and a half because folks are driving from Grand Junction for care, and it was really pressuring Colorado General's finance. So we know that on a large scale for uninsurance, this business model does not work. This is a demonstration project, if you will, where we don't have any billing needs, and so we're able to show what capitated, risk-adjusted, basically team-based primary care would look like for our students. And so, when you look at the zip codes and census tracts surrounding Anschutz, it was 45 to 47% in 2010, the rates of uninsurance. That's in a community of about 65,000 people in that neighborhood. So 30-something thousand patients we wouldn't be able to deal with at the Dawn Clinic. Since Medicaid expansion, we're proud one of our top partners, the Aurora Community Connection, was the highest health insurance enrollment site in the state. And now we're in single-digit rates of health uninsurance, and those patients that are insurable are routed to the CIVHC networks or other primary care access points, and we're left with the uninsurable population, which is a manageable number and allows us to do what we do. If we go backwards, then we're back to where we were before, and that was in 2013. Jeff Thompson, the community corporate relations guy at the university, quotes $330 million of unreimbursed care from UCH alone. I have no interest in managing a budget of that size. I'm a teacher and a organizer, and that's just not reality based. That we'd be able to find the workforce right now, leveraging students to provide that. If Will Cook, the CEO of the university, comes to me and says, Dr. Johnson, let it rip, we'll give it our best college try, but that's not a controlled transition by any stretch of the imagination. So I think the educational experience, the finances, and sort of our community-based connections, those would not meet demand by a long shot. That being said, I think that this model of care that focuses on a primary care teamlet as an individual entity is what needs to be funded. I think that the Affordable Care Act is a start. Folks need insurance. I would personally advocate for a single payer system that equitably ensures that every member of our country and citizenry has access to a baseline primary care team in an interprofessional fashion. And I would take ideas from our Republican colleagues on the other side of the divide from me, who are supportive of pre-tax dollars and health savings accounts being able to be used to purchase the frills from any basic package that's given. From there, if you want to use your HSA dollars to subscribe to acupuncture services or sort of more frequent stress testing than is recommended by guidelines, by all means, you can do that, but that's coming out of your private HSA dollars, supplemental insurances, things like that. And I would advocate that a single payer system, that we eliminate insurance companies entirely, and we contract directly with risk-adjusted per member per month payments to primary care organizations that in turn, just as the Dawn Clinic is acting in partnership with Anschutz, becomes sort of the financier and delivery system. We see a similar arrangement with the PACE program, like Innovate, where I work now. And I think that's probably what we're trying to demonstrate, that you really remove the billing and you get passionate people in there and you work as a team, that I can deliver better outcomes at the Dawn Clinic than they can in many private fee-for-service settings as well. And we're moving in that direction. Just this past year, our hypertensive control was already better than the Colorado Medicaid average. And that's before we had our nurse. Our longitudinal pharmacy students have really taken ownership of our population before we've instituted risk stratification of our entire population of patients, and sort of really put in some of that meat to how we keep track of people.
Well, we only have about 4 minutes left, Joe, and we know that you're going to have to get back to patients right at the bottom of the hour. So I just want to tell you that somebody put in the chat box, bravo, Joe. And so we'd like to echo that there. That's really impressive. Sorry?
He's on our board at Dawn Clinic, so I don't know if he counts, Denise.
He's a plant? Okay. But, well, we're not on your board, and we're very impressed with the work, and really hope that, I mean, it's clear that you've been thoughtful basically about the approach, and actually how this has implications for the larger healthcare system. This is not simply a one-off, but really a manifestation of how you view the health system to work in an ideal state. That, you know, get the billing out of the way, guarantee primary care to everybody, and then people can buy up to other stuff that they want, but at least that portion should be guaranteed for everybody who's in this country, is what I take away from that.
If we can deliver the workforce. I mean, right now we can't. And
Yeah.
That to me is the most pressing issue we're facing. We're at a steady state with most folks having at least some modicum of access and insurance with the ACA. But we are still so far from having the workforce we need. We're so far from incentivizing the right aspects of promoting ambulatory care as a career option. I love it. I think that's delivering everything that I wanted in my career and my day-to-day, but you know, more for nursing. Honestly, I think nursing is the crux of a powerful population health management based primary care operation, and we just don't see that right now in nursing education.
Yeah.
I think that's the number one place we need to start. That's what we're trying to do at Dawn, and we're really looking forward to partnering with Sally Garcia and our new employee this coming year to negotiate with the nursing school to explore curricular reform and to really see where we can run with this now that we're feeling sustainable, stable, and grounded with the community and our population.
Yeah. Well, we can't agree more, and I'm toying with the thought of sending this video to our congressional delegation because they seem to have run out of ideas in Washington, at least for the short term. So
we'd be happy to.
Sorry?
I'd be happy to further discuss that with our representatives. I know Senator Fields.
Great.
Senator Fields is the #1 benefactor of this clinic, and we operate under her name and tax code. So we're certainly working on our end as well.
Awesome. Well, thanks so much, Dr. Johnson. We really appreciate you for joining us and really sharing, you know, what is really a fantastic experience and a fantastic construct. Thanks to everybody who also joined as well. And the recording of this discussion will be shared via social media and on the Civic website on Monday. In August, things will switch a little bit for this show, and we'll be moving the chats to the second Friday of each month. In addition, I wanted to extend my thanks to all of you out there. This is my final chat as I move on to another assignment in New York City. And I want to tell you that it's been an absolute delight and a pleasure basically to serve as your host. I've learned a ton basically just by hosting these, and it's been a great pleasure and a privilege. Our next chat will be on Friday, August 11th, when we'll be chatting with Dr. Cobb, the Regional Council of Governments, about their programs for older Coloradans and how they evaluate cost savings and outcomes. Your host at that point will be Carrie Frank, who is our Director of Communications. Thanks again. Everybody have a great weekend, and right on, Joe. Great to have you and great to talk with you. Bye-bye.
And lastly, so if anyone is interested in volunteering with the Dawn Clinic, by all means, please reach out through Jay and Stephanie or directly to myself at joseph.johnson@dawnclinic.org. We only exist through the time investments of our volunteer providers. So any interest or referrals of patients or providers, send them my way.
Great. We're more than happy to forward any inquiries or interest on to you, and we hope we get a lot of those. Thanks again.
Thanks, everybody.